Hello, good evening, everybody. My name's Melanie Dobromilski. I'm one of the heads of pathology at VPG, and I'd like to welcome everybody this evening to this webinar on feline gastrointestinal eosinophilic sclerosing fibroplasia. And yes, I agree, it's an absolutely awful name for a disease, and I'm probably going to spend the next 45 minutes seeing how many times I can get away with not saying it out in full. If anybody has a good suggestion for a better name for it, I'd be absolutely delighted to hear from you. Everybody I've worked with on this disease, I've said, please can we come up with a better name? And as yet, we've yet to come up with a really good suggestion. So I'm all ears. So for the next 45 minutes, I'm just going to walk you through really what we know about this disease. So I'll start with the history of feline gastrointestinal eosinophilic sclerosing fibroplasia, where we started, and then try and summarize all of the information we've sort of gathered in the last 16, 17 years about this disease. And so I'm going to try and hopefully present all of that information to you, so we can learn about how it presents from a clinical point of view, but also what it looks like to the pathologist down the microscope. And then we'll look at, what is the actual cause of this disease, this entity in cats? Is it infectious and we're actually just missing those infectious agents? Or is it something else? Are some of these something sinister like an underlying lymphoma, for example? And then I'm going to share a little bit with you about what we're doing at the moment in terms of trying to understand this disease better. So watch this space. But we'll start back in 2009 with the very first paper that was published in Veterinary Pathology by Lyndon Craig et al., where this disease was described for the very first time. There was a retrospective study that had 25 cases, so not a bad sized study actually for a disease that's being described for the very first time, but very much focused on sort of describing the very characteristic appearance of this lesion that we see down the microscope. So in that series of 25 cases, they had a set of masses. Some cases could have one mass, but others could have more than one mass. And they were typically associated with the gastrointestinal tract and the abdominal lymph nodes. Even in this very first study, they picked out that there were some very common sites for these lesions to occur, one of those being near the pylorus and the other being the ileocecal junction. As I said, they've got a really characteristic appearance on histopathology, and a bit later on in this talk, I'll show you some slides and show you what they look like and why they are so striking for us pathologists. But even at this early stage, the pathogenesis was very poorly understood, and the hypothesis was that this was some kind of aberrant response to antigens, perhaps from bacteria or parasites or fungi. So if you go to PubMed and you actually do a search for this disease entity, this is the graph you get of all the publications we've had since that very first paper in 2009 from Lyndon Craig et al. So as you can see, there aren't a huge number of studies, but there have been a number over the years, and we'll look at some of those in a bit more detail. Many of these have been case reports, and obviously these are very important because they give us some insight into all the different ways that these can actually occur. And every case report and every series sort of gives us a little bit more information about them. So I will try and summarize all of this information in later slides in the talk so we have it. But I will start by going through some of the key papers. So that first one in 2009, retrospective study, that was the very first report. And then in 2015, we had another very important study from Michael Linton. So he had a case series of 13 cases, but he also looked back and he sort of summarized all the knowledge that we had about this disease up until that point. And for a very long time, when we had a case of this and we were sending out that biopsy report, the Linton study was the one that we referenced, because vets would get on the phone to us and they'd be saying, oh, I've never even heard of this disease. What on earth is it? And Linton was the reference that we were directing people to. And then it went a bit quiet for a while, and we just had, a case report here, a case report there. And then this is where I got involved. I was involved in the case report around sort of 2021, where we described a particular case that came into us. And that got me kind of interested in the disease, and I started thinking a bit more about it. But more recently, we've had a kind of uptick in particular case studies, but also larger studies as well, trying to characterize this disease a bit further. And one of those was a very important study by Petra Cerner, where she had a set of 60 cases with a lot of detail. And I'll look at that paper as well in the later part of this talk. But let's start with that very first study in 2009. So as I say, 25 cases. And already in that very first study, we were picking out certain sites that appeared to be predisposed to developing this particular lesion, the pyloric sphincter being one of them, and the ileocecal junction being the other. But other sites in the small intestine were also reported as being potentially affected. And 7 of these cases actually had involvement of lymph nodes as well. And that was one of the scary things about this disease, is that it can mimic a neoplastic process, because you can have a primary GI mass and then you can have lymph node involvement. So that can start to mimic metastatic disease, and that's something that can sometimes catch people out. In that first study, they found evidence of bacteria in just over half of the cases they looked at. They also found that peripheral eosinophilia was a very common finding in these. The main clinical signs they described were vomiting and the presence of an intra-abdominal mass. Some of the cases also had other signs like chronic diarrhea. Have a very wide range of the time interval. So some of these cases had days of clinical signs and others went on for years. Had a whole mixture of breeds that they reported, a mean age of 8 to 9 years, and already a slight male predisposition to developing this particular disease. So in Michael Linton's paper in 2015, very similar. Again, they found that the pylorus or the ileocecal junction were quite commonly affected sites. In that study, they found bacteria in 69% of cases, so quite a significant proportion had bacteria associated with them. Again, peripheral eosinophilia was an important sign. Clinical signs: weight loss, chronic vomiting, and/or diarrhea. Again, could be affected for days up to years. And interestingly, this was the first time that ragdolls were flagged as being apparently predisposed to developing this particular condition, and very similar findings in terms of median of 7 years of age, and again, males being overrepresented in that population. So this was a case study that I was involved in a few years ago now. So it's myself and colleagues at Pathologists and also clinicians over at Lumbury Park. So rewrote this one up primarily because it had a particular cavitated appearance on imaging. And over the years, various case reports have sort of added more and more information to what we know about this really unusual disease. But you can see here the image of this mass at surgery, and these can be really scary looking. I mean, you look at that and you think that has to be a tumor, right? So vets are often very surprised when they get the diagnosis of this instead of a tumor, because it's certainly not what they're necessarily expecting. But let me share with you some of the histopathology from that particular case report. So unfortunately, I haven't got a pointer, so I can't really point to things on the slide, but I'll do my best to describe what we've got. So in the bottom left-hand corner, you can see a cross-section through more normal-looking gastrointestinal tract. So in the middle, you've got the mucosa, then the submucosa, then the muscularis layer around the outside. And then in the larger piece of tissue, you can see down at the bottom, you can see just the edge of the mucosa, the submucosa, and then the mass itself, as you can see, is mostly within the muscular layers, and it's really markedly expanding the muscular layers, and it's kind of multinodular, multilobulated looking. So these are masses which are often located quite deep within the wall of the intestine itself, not necessarily affecting the mucosa, although they can affect the mucosa and extend deep, but they are primarily deep within the wall. And you can see in this low power view, you've also got these little pockets of more brightly pink material. And this is what they would look like on a slightly higher power view. So these are areas of necrosis and very degenerate cells. And sometimes when you look in here, you can see bacteria, for example. You could do a special stain like a gram to make them really stand out. But you can't always find bacteria in these lesions, despite the fact that we always look for them. And then you can see in the surrounding tissues, you can see these bands of quite pink material. So this is the sclerosing fibroplasia part of the name. So it's a very characteristic feature that we see in histology for these lesions. So these bands and what we call trabeculae of very sclerosing looking fibroplasia. And they've got this neat sort of interweaving pattern where they sort of coalesce and divide. It's a very, very characteristic feature of this disease, a very distinctive pattern that we wouldn't normally see. And then if you look on a much higher power view, so between those sort of pink bands of fibroplasia, you have quite a mixed cell population. And in my experience, this can be a bit variable between the cases, but what you would expect to see would be eosinophils, hence the eosinophilic part of the name. They can be present in large numbers or only very small numbers. It's quite variable, thinking back to all the cases that I've seen. Also in there, you'll have these spindle-shaped looking cells, so that's your fibroblasts, very reactive looking sometimes, but you'll also have other cell types in there as well. So you'll probably have some macrophages in there, some plasma cells, maybe some lymphocytes. So quite a lot going on, lots for the pathologist to be looking at. And then this is a collagen stain. So this just helps to really, really highlight that particular pattern that we see, the sclerosing fibroplasia. So in the previous image, these were pink, those sort of bands, sort of anastomosing and branching. But you can see in this stain, they're colored a really nice blue. And it just makes it really, really stand out, that really regular pattern of arrangement that we see in these particular lesions. And it's a very, very specific pattern that we see in these particular masses. So that case report kind of got me thinking about this disease and the fact that there wasn't, within the literature, there weren't particularly large numbers of cases in the studies that were out at the time. And somebody said to me, oh, why don't you look at the laboratory database and see just how many cases you've got that's been diagnosed through your lab on biopsy, for example. It could be that you've got quite a decent collection of cases sitting there. So I thought, oh, that's a good idea. Let's do that. Let's search through our records and see just how many of these cases we have diagnosed. So this is another picture of a case. So this one was in the gastric mucosa. You can see the lower power view at the top, and then underneath that, a slightly higher power view where you can see, hopefully you can see those bands of sclerosing fibroplasia again. And then this particular case, we can also see some early involvement of the lymph node as well, which is in that other picture on the top left. So we had a look through our database and much to my excitement, we identified 78 cases in our records. So this was very much a retrospective review, and we were able to go through those records and pick out various bits of information about the signalment. So the age, the gender, the breed of the cases that those samples had come from. And also we were able to look at the anatomical location of the lesions where that information was provided, and also the clinical history that was coming in terms of the presenting clinical signs. So within that group of 78 cases, we had 71 where we knew what the age was. So when we looked at that, it was very similar to the previous studies. We had a median of 8 and a median of about 9 years old. But I thought what was really interesting we saw was really wide range. So anything from 11 months old up to 16 and a half years old within our cohort. So a really wide range of ages that could be potentially affected by this disease. And I think we saw something of a biphasic age distribution. So we had a peak in cases in a sort of lower age of about 3 to 4, and then a second peak at age around 11. So I thought that was really interesting. With slightly more cases that we sort of started to see this two different peaks, so biphasic age distribution there. When we looked at the gender, we did have more males than females, but in our particular cohort, we didn't reach statistical significance there. So, but similar to previous studies, it appears that males are more often affected than females. In terms of the clinical history, obviously, we were dependent on what had been written on those submission forms that came with the samples. So when I analysed those, I decided to use a word cloud. I'm sure everyone knows how word clouds work, but basically, the more frequently a particular word was present in the clinical histories, when we pulled them all together, the bigger that word is on this diagram on the page. So you can see, looking at this, the really frequent words that we had on those submission forms were mass, lymph node, abdominal, enlarged, mesenteric. So all the things that you would probably expect. But what I thought was very interesting was actually there's a huge number of other words that we saw as well. And I think this reflects the fact that this can present in quite a lot of different ways depending on your case. So some of them are obviously gastric, some of them are in the colon, some of them are rectal, different sort of clinical signs that might come with that. So some of them absolutely, they were an incidental finding. They had no clinical signs. They just, the cat came in for another reason. They did an abdominal palpation and they found a mass. Some of these cats were lethargic. Some had anemia. Some had jaundice. So particularly those masses arising around the area of the pylorus, for example, if you've got obstruction of the biliary tract, they could present differently to ones with masses elsewhere. Some of them are clinically well. So quite a huge range of words that were coming up in the clinical histories, lots of different sort of presenting clinical signs. So some degree of variation there. We looked at breeds, and this was very, very interesting. So obviously we had a really nice cohort of 78 cases, and we were able to compare the numbers of the different breeds that were affected with the background population of cats. So we compared it to the breeds of all of the cats that had samples submitted to the lab over the same time period, so a big background population. And we definitely found that a number of breeds appeared to be at increased risk of developing this particular problem. Ragdolls has already been picked out, but also Burmans, exotics, and Siberian or New Forest cats, they came out as well at an increased risk. And when we compared those breeds to the domestic short hair, domestic long hair, so the sort of non-pedigree breeds, we could work out the odds ratios for those, and particularly the ragdolls. And I'm saying this as an owner of 2 ragdolls, they had 14 times the risk of developing this type of lesion compared to the domestic short hair and long hair cats. So quite a pronounced increased risk for that particular breed. When we look at the sites where these masses were arising, and again, very much we're dependent on the information that was given to us on those submission forms. But again, I think this is really interesting just because we had such a large number of cases in our cohort. So you can see, again, we've got a lot in the stomach and the pylorus and the duodenum. That's definitely a hot spot. We've also got quite a cluster at the ileocecocolic junction. We've also got quite a lot affecting mesenteric lymph nodes, and that can be either as well as a gastrointestinal mass or just as an isolated individual mass. And we've also got some other sites that might suggest lymph node involvement. So one was in a lymph node near the kidney, for example, and we've got a cluster of them affecting the root of the mesentery. Again, I think that's probably a lymph node that's the primary affected site there. So very interesting that we can get these lesions at all sorts of different sites, but there's definitely some sites which appear to be at increased risk, and we don't really fully understand why that is yet. So I also wanted to give a shout out to this lovely group there on Facebook. It's a support group. It's people who have cats who've had this diagnosis supporting one another, but also acting as a source of information for vets who maybe haven't got a lot of experience in managing these cases. There's a lot of us in there who try and contribute where we can. So I'm on there, Michael Linton's on there. It's just a really, really friendly group, a very, very supportive group to reach out. And if you've got owners with cats that are dealing with this, it's a really nice resource for them to reach out to. And they've been really supportive. So every time I've done a presentation or presented a poster, they've been very happy for me to use this map. And it was very interesting because they just wanted to have a map of all the places where cats had this diagnosis, just to show what a widespread distribution it is. So I just thought it was a very striking pattern of distribution. So we see this disease all around the world. So what were the main findings for our sort of retrospective review of 78 cases? They were largely in agreement with the previous study with Michael Linton, 2015, albeit we had quite a bit of a larger cohort. Most commonly reported clinical findings: abdominal mass or an enlarged lymph node. Therefore, you should definitely consider this as a differential diagnosis when you identify an abdominal mass in the cat. And even if you find an abdominal mass and an enlarged lymph node, you should still have this one on your differential list. And I think that's really important. And I suspect that presenting signs are partly due to where in your particular case the mass is located, so the anatomical location and also just the physical presence of a mass. So, for example, if you've got one in the stomach and it's physically causing an obstruction, then you're probably more likely to see vomiting as one of the clinical signs. If it's involving the outflow of the biliary duct, for example, then you may well get things like jaundice. So I think that, some of what you see clinically might be partly due just to the physical location of that mass. I think it's really interesting that our cases showed this biphasic age distribution, so a cluster in younger cats and then a second cluster in slightly older cats. And that made me start to question whether this is really a single disease entity with one specific cause, or whether it was a bit more complicated than that. And either we have multiple factors at play or different diseases that are manifesting in a similar way. So I think that's something that we need to have an open mind about. We also found ragdolls, Burmans, exotics, and Norwegian forest cats statistically more likely to have this disease, and particularly ragdolls with the 14 times the odds of having this particular disease compared to domestic short hairs, domestic long hairs. And anecdotally, ragdolls are most frequently cited pedigree breeds are diagnosed with this condition around the world. So it's definitely they're at risk. So I presented these findings as a poster and an abstract at the World Feline Conference in 2023. And whilst I was there, I met for the first time Petra Cerner, and she had her particular study. It was under review at the time, and she's done this great study with 60 cats with this condition, and she's got all the clinico-pathological findings, treatment and outcome. So this is a really, really important study, and I will go through some of her findings in the next part of the talk. But it was a delight to meet Petra, and she told me about the study that she had, manuscript in review, and we decided at that point that we really needed to combine forces and see what we could do in terms of further research to try and work out what on earth this disease really was. So let's have a look at Petra's paper compared to the 2009 and the 2015. So 60 cases, so a great collection. Some of the findings were quite similar. So she again found that the ileocephalic junction and the stomach, the pylorus, being very sort of hotspots for this, but really anywhere in the small intestinal tract could be affected. She had involvement of lymph nodes in 8% of her cases, so not uncommon, and 15% had more than one mass. So again, multifocal lesions, which makes you think neoplasia, but you should still have this disease on your differential list. In terms of infectious agents, she only found bacteria in 32% of her cases, and she did have one case that was fungal in origin, and there have been case reports of these lesions being associated with fungal infections in the past, so that's really interesting. Again, peripheral eosinophilia, clinical signs, weight loss, anorexia, chronic vomiting, diarrhea, lethargy, so again, very similar. Time span, again, anything from days to years. And again, she found predisposed breeds similar to us, ragdolls, again, but also Persians, so that's slightly different. Her median age was slightly younger, so she got a median age of 5.4 years, but she actually had a median survival time of 925. So I think that's another really important thing that we need to look at, is just what the outcome is with some of these cases as well, because it's not always as bad as you might think it is. Just wanted to put in this paper as well, another fairly recent publication focusing more on what these masses can look like on ultrasound. Again, 30 cases, so a good collection of cases, and it just describes the findings. Now, I'm no imager, so I'm not going to go through this in detail because it's absolutely not my area of expertise, but I think it's very, very useful for people to know how these can look like on ultrasound. So yeah, in their cohort of 30, they had 25 had masses affecting the gastrointestinal tract, 3 had lymph nodes, proximal duodenum seemed to be the main site, and they were talking about a focal mass with loss of layering, circumferential thickening, so think back to the histological picture that I showed you earlier, that kind of makes sense, eccentric growth, and then quite heterogeneous in the echogenicity as well. Again, and they did find enlargement of lymph nodes, again, something that makes you think neoplasia, but not necessarily in this case. So trying to summarize all those different publications over the years, and also sort of putting in the bits of information we get from case reports as well, because there's been quite a number of case reports over the years that just sort of help to demonstrate how variable this disease can be on presentation. So over the years, it's been found at all sorts of different sites. So we started off thinking it was gastrointestinal, but then we've had cases which are only in the mesentery. We have those cases with multiple masses, doesn't seem to be that uncommon. And then we see it reported in some other sites, so rectal, for example, liver, and then sometimes not even within the abdominal cavity, so retroperitoneal, nasal, bicavitary, intrathoracic. So suddenly it's not necessarily strictly gastrointestinal, so maybe we could lose the G from the name, but we're starting to see at other sites as well. So maybe this is more of a generic tissue reaction pattern rather than something that's specific to the gastrointestinal tract, which I think is really, really interesting. And then when it looks at causes, so obviously there's been case reports and studies that have found bacteria in some of these, but not all. And then there's been other case reports where nematodes have been seen associated with the lesion or various fungal agents. I think it's important to also point out that although bacteria can sometimes be isolated or cultured, they're not of a specific type. So there's been lots of different types of bacteria identified in different cases, and not even the morphology is similar. So it's a complete mixture of different bacteria that have been seen associated with some of these masses. And in many cases, we can't find any infectious agents at all so far. So that's a big question mark. And then we've got some studies that are sort of helping us understand how these might look like on imaging. So they can have a cavitated appearance, for example, but also studies looking at how they can look on ultrasound and also CT. So just, all of these case reports are adding little extra bits of information. So I think it's really important to try and sort of remember all of those when we're thinking about this disease. In terms of outcome and survival times, I think this is really interesting. So even in those earlier studies, so Lyndon Craig in 2009 and Michael Linton in 2015, some of these cases actually had quite a long survival time. So Lyndon Craig goes out to 800 days. You can't see Michael Linton because I'm covering it with my face, but it goes out to about 3,500 days. So some of these cats can survive a long time. And then you look at some of the different treatment options that have been tried, so whether that's surgery, a combination of surgery and medical management, whether they've had prednisolone, whether they've had antibiotics. And suddenly you can start to see actually the ones on prednisolone in that very first study actually seem to do the best. And even in Michael Linton's study, the ones that had medical management, either on its own or in combination with surgery, tended to do slightly better as well. Although in both of those studies, there is an initially quite a sharp drop-off. So quite a few cats that sort of didn't survive very far beyond that initial perioperative period, which again is something that we do sometimes see. But then if we go through the findings in Petra's study, so that's the 60 cases, she found some really, really interesting things in terms of outcome and survival times and the different treatment modalities. So the graph on the left is showing survival time for, in green line at the top, the masses that were surgically removed, and then the blue line underneath, the mass was not removed. So the thing that she found made all the difference for these cats was treatment with prednisolone. So it's really, really interesting. So she found no statistical significance in the differences in survival times for cases where they had full surgical resection versus just medical therapy alone. No difference if the case had complete resection of the mass versus only incomplete resection versus only just a biopsy for diagnosis. No statistical difference between outcome for those cases that were treated with corticosteroids only versus those which had corticosteroids and a secondary immunosuppressive agent, and no difference between those that had antibiotics or not. So I think that's really, really significant finding. And if you only take away one message from this talk, I'd like it to be that corticosteroids are important in the treatment of cats with this disease, because they really do, for certain cases, seem to make all of the difference. So in Petra's study, 98% of cats were treated with corticosteroids. And what's really interesting is she had some cases where the prednisolone was discontinued, and quite a high number of those had to restart the prednisolone because they had recurrence of their clinical signs. And some cases where they didn't have corticosteroids had recurrence of the masses, started on steroids and then had no recurrence thereafter. And one cat even managed to develop another mass when its steroids were stopped, had to start the steroids again, and again had no recurrence for a prolonged period after that. So if you take away only one message, it's that if you have a cat that's diagnosed with this, corticosteroids are likely to be very important in the management of that case. She also looked at some of the other treatments that people were trying for this disease. So some cases were given a secondary immunosuppressive agent, but quite a few of those were discontinued after a certain period of time. 72% of cases were given antibiotics, which I think is kind of understandable given that some of these cases do have bacteria involved, all sorts of different antibiotics, and again quite a range of treatment periods as well. And then some of these cases they did try protein diet trials, And, a certain proportion of them did show improvement in clinical signs as well. So I think all of this is really interesting, and all of these things can also help. But the prednisolone seemed to be the thing that really, really made the difference for these cases. In terms of infectious agents, she found on histopath, 32% of cases, they were able to find bacteria actually in the lesions themselves. Again, different types of bacteria were being identified, Enterococcus, E. coli. One of her cats had Candida cultured as well, so had a fungal involvement. If you're using kind of more molecular-based techniques to look for bacteria, so FISH or fluorescence in situ hybridization, she had 3 cats that had that done, and 2 of those cases, again, they identified bacteria in the lesion. And then 30% of cases had bacterial culture performed as well. 22% of those were negative. So again, despite all the different ways that we're looking for the infectious agents, we still don't always necessarily manage to find them. So I suspect that this might not be only an infectious disease type problem. They might be in there in some lesions, whether they're the primary cause or just secondary opportunistic, I don't know, but we can't always find them. So I think maybe something else is going on. In the last couple of years, there's been a couple of papers that are sort of looking more at the pathogenesis of these lesions. So why do we see, all of the eosinophils in there? Why do we see that really distinctive pattern of fibroplasia with those bands that I showed you earlier on? So this particular study was looking at activation of eosinophils. So I said earlier, these lesions nearly always have eosinophils in there somewhere, sometimes in very large numbers. So this paper described the fact that these eosinophils become activated. They're releasing what we call fibrogenic mediators, so that's cytokines that drive fibroblast proliferation. So you saw in that high power view all those spindle-shaped cells in there, which were quite activated and proliferating. And it also drives the deposition of extracellular matrix. So that's that fibroplasia, those bands that I showed you earlier on as well. So we think the main players were interleukin-1 beta and TGF beta 1. And also they looked at kind of the maturation of these lesions. So this paper described in the early stages, you tend to have a particular type of collagen, so type 3 collagen. And then as the lesion ages or matures, the increased levels of those particular cytokines seems to drive the type of collagen that's being produced, and it becomes more of a type 1 collagen. So we're just starting to pick out sort of the more molecular and immunology underlying these lesions, and maybe why and how they develop. And then the second study came out just last year. So they were looking in a bit more detail at those cell populations that are there between those bands of fibroplasia. So they were looking at the spindle cells, and they used immunohistochemistry to show that they were expressing a marker for smooth muscle called smooth muscle actin. So they postulated that this was driving a myofibroblast type phenotype within that spindle cell population. They were also interested in looking at the macrophages. So these are positive for a marker called IBA1. And interestingly, within that mixed cell population between those bands of fibroplasia, they found some cells were positive for both the smooth muscle marker and the macrophage marker. So they think there may be a process whereby there's a transition from macrophages into more of a myofibroblast type phenotype. So we're only just starting to try and pick apart what's going on with all of those cells and the cytokines and everything that's going on in these lesions. But I think it's very interesting to try and work out what on earth's going on in there. So I don't know about you, but at this point in time, I've got a lot of questions about this disease, more questions than answers, I think. The pathogenesis, I still don't think we fully understand the pathogenesis of these lesions. Is this infectious or is it not? And if it is infectious, are we just missing the infectious agents? We might be, and it would be interesting to try and look more closely to see if we can pick out infectious agents in some cases where they're not immediately obvious. But I think it's interesting that even in those cases where we do find bacteria or fungi, it's not a consistent type of bacteria. So it could be a number of different types of bacteria. Even the morphology is variable. So that makes me question whether that's really a primary cause or whether these are just secondary opportunistic pathogens that are taking advantage of the fact that this lesion is there and developing. Why do some of our cases respond really well to prednisolone? So what is it we're treating there? Are we treating an inflammatory process, for example? And that might sort of suggest that maybe the infectious diseases, the infectious cause is maybe not as likely, because, you know, why would that work? You know, so are we suppressing an aberrant inflammatory process in these cats? And is that why they do well with PRED even without the surgery? But then even with PRED, we do have a small number of cases that just do really badly, and they, you know, they might not really survive that perioperative period. They may, you know, they do really bad clinically within days, and unfortunately they don't survive. So even with PRED, there are some that just don't respond to treatment. And why is that? Why are certain sites in the gastrointestinal tract predisposed? So I was saying the pylorus and the ileocecal junction. A colleague of mine suggested that maybe this is because at these particular sites in the gastrointestinal tract, that the tract is undertaking quite a sharp turn or change in direction. Is something getting stuck there? Are these sites predisposed to some sort of mucosal trauma, and that's allowing, you know, an infectious agent into the deeper tissues in the wall? Or do they become obstructed in those areas? I don't know. I think that's an interesting suggestion. I think maybe, possibly, something that needs to sort of be looked into. And then why have we got this interesting biphagic age distribution in our larger cohort? So we have that cluster of sort of younger cats, and then we have that second larger cluster of older cats, giving us a kind of median of 8 or 9, but actually, you know, one peak at 3 and another peak at 11. And I wonder if that's because this might be more than one disease, or more than one cause. And what we're seeing in our tissue sections is just a tissue pattern reaction. And there are different things that can cause that, some of which may be more apparent in younger cats and some in older cats. Why are ragdolls so predisposed? And as I've said, I share my life with 2 ragdolls, so this is really worrying for me. So is there a genetic component to this? You know, is there something in their genetic background that just makes them really predisposed to having these lesions and having eosinophils come in and be super activated? And then why do we get these cases where it appears that these lesions are affecting only a lymph node, and we can't find a primary lesion anywhere else? So it seems to be primarily arising in the lymph node. And those are really interesting as well, because, you know, that's not associated with trauma to the mucosa and penetrating injury. It's in the lymph node, and you can speak to these vets and they're absolutely sure there's no lesions anywhere else. It's only affecting a lymph node. So I feel like there's so much we don't understand about this disease, and we've got a lot more to try and sort of work out. So that's kind of the sort of more of the clinical side. Meanwhile, in pathology land, and sort of slightly as an aside, because I didn't really straight away put these things together, we definitely saw a set of cases in cats where we get an enlarged mesenteric lymph node, and they had this really distinctive appearance down the microscope. So you've got one in the picture here. It's a low power view of a mesenteric lymph node. And you can see around the edge, it's kind of got this thick fibrous band. So rather than a nice thin capsule, which you could barely see at low power, you've got this slightly thicker band of fibroplasia going on. And although you can still see a certain amount of lymph node architecture as being retained, and there's even some lymphoid follicles in there, when you look on higher power, what you've got in the lymph node is very, very large numbers of eosinophils, and then an atypical looking round cell population and a very distinctive look to it. And I was worried that these were some form of lymphoma. And if you do immunohistochemistry on these, they'll often show some positive staining for the T cell marker CD3, but it's very aberrant, so abnormal staining. So in my head, you know, this was a sort of T cell lymphoma in cats, lots and lots of eosinophils with this weird fibroplasia associated with it. And again, if you speak to the vets and you say, oh, you know, is there a primary GI mass? This must be metastatic to lymph nodes, so there must be a primary somewhere. The vets would swear absolutely blind there were no lesions anywhere else in the GI tract, and this was primarily a lymph node lesion. And, you know, having spoken to several of the vets, I believe them. So this is, in my head, this was a weird form of lymphoma that was seen in cats but hadn't really been described yet. So I was absolutely delighted when this case study came out describing exactly this. And it's funny because sometimes as a pathologist, you sit there thinking, I'm sure this is a thing. I'm sure I keep seeing this, but it's not described anywhere. And then someone else comes along and describes it, like, thank you. It's not just me. I'm not imagining it. So these guys, they wrote up a case and it sounded exactly like this. So it is primarily a lymph node disease. It's a form of T-cell lymphoma, very large numbers of eosinophils and causing this very sort of characteristic fibroplasia in the lymph node. So that made me relieved that I wasn't sort of imagining these cases, and also very intrigued as to what's going on with these cats. And then just last year, we had another paper came out in Veterinary Pathology, and again, very similarly describing this form of mesenteric lymph nodes impacted with this form of eosinophilic T-cell lymphoma or natural killer cell lymphoma, again with fibroplasia. And this particular study was really great. So it says, no, these can look really, really like feline eosinophilic sclerosing fibroplasia. So suddenly, not only have we got this, we're looking for infectious diseases and agents in there. Suddenly we've now got to think, oh my goodness, some of these masses could actually be a lymphoma, and they're just hiding in amongst all the fibroplasia and the eosinophilia. So suddenly we've got, a problem. So if you remember this picture from earlier on in the talk, and I said about all those different cells that we get between the bands of fibroplasia, and we get eosinophils, and we get reactive fibroblasts, and we get macrophages and plasma cells. Now, as pathologists, we've got to be looking really, really carefully for these atypical round cells, because we've got to be asking ourselves, could this be a form of eosinophil-rich lymphoma? Could it be one of these T-cell or NK cell lymphomas that's masquerading as this particular fibroplasia? So we've got to really be having our eyes open and looking for this now. Less likely mast cell tumour, because they can have eosinophils too. I don't think these are mast cell tumours. I think some of these, and I do wonder if these are the ones that do really badly and only survive days or weeks, they're actually a form of lymphoma that is masquerading as gastrointestinal eosinophilic sclerosing fibroplasia. So that's one that pathologists have really got to keep their eyes open for. And it's very interesting. So here's that case I just shared with you. This is from a colleague called Ladislav's, very kindly allowed me to share it with you. So that really characteristic appearance on low power with the fibroplasia, often around the outside. And then on higher power view, which you can't really see on this slide, unfortunately, but there is an atypical round cell population in there. If you do immunohistochemistry in the top right corner, that's our marker for T cells, that's a CD3. The more densely staining brown cells you can see, they're just the normal or reactive T cells. So that's how a T cell should stain. And I don't know if you can quite see it, but in the background, the other cells have got just that slightly faint brown staining, so a sort of very faint aberrant staining for T cells. And then in the bottom right corner, this is a new marker. So this is CD56 that they used in that study to identify NK cells. So some of these are actually NK cell lymphomas. So that's one that we need to keep our eyes open for as well. So a lot of things are happening in the world of feline gastrointestinal eosinophilic sclerosing fibroplasia at the moment. It's a very interesting time to be involved in this particular disease. I think we're still learning a lot, but there's still a lot we don't really understand. So I said earlier on that Petra and myself decided that we were going to join forces and combine our resources and see just how many cases we could get between us. But we wanted cases where we had really good clinical data, preferably with treatment and outcomes, as well as all of the clinical history. And we also wanted access to the tissues for those so that we could do repeat histopathological assessment. And we're trying to do a scoring system. So we're trying to look at certain characteristics. So the degree of fibroplasia, how reactive the fibroblasts look, how many eosinophils there are. If there's anything in there that the pathologist can try and pull out at that early stage that might give us some idea as to how that particular case is likely to behave. And now, of course, we've also got other advanced testing for infectious agents. So we're going to be using PCR and FISH to look at these to see, can we find infectious agents in more of these cases if we use slightly more sensitive techniques to try and find them. And then given what we now know about lymphoma sometimes hiding in there, for certain cases, we can also do immunohistochemistry looking for T cells and NK cells. So whether some of those cases will actually turn out to be lymphoma, and we'll get better at identifying those. We can do special stains for mast cell tumor, so GEMSA, and we can do special stains for infectious agents, so Gram for bacteria and PAS for fungi. And then we're going to take all of that information, so the histopathological assessment, the advanced testing for infectious agents, the IHC, the special stains, the scoring, put it together with the signalment and the clinical signs and the treatments, and then look at outcome. So what we're really hoping is to get a better understanding of what is the pathogenesis behind these cases, but also is there something we can pull out from the histopath that will help us to help you know what to do with a particular case and what the expected outcome is likely to be. So we're in the middle of this at the moment. It's a very big, ambitious study. It's very exciting. Watch this space for when we finally get around to analysing it all and publishing those results. But I hope by working together, we'll get a much better understanding of what these actually are. And so just to round up, I've got some key take-home messages for you. The first one being not all abdominal masses are neoplastic, even those where you think you've also got an enlarged lymph node. Have this on your differential list. The second key message is the prognosis is better than previously reported, particularly for those cats that survive the perioperative period. So there are a small number of cats that don't do well, and my suspicion is they might be a lymphoma that's lurking in there. But if you have a cat that does well and survives the perioperative period, even if you can't manage full surgical resection, the prognosis can be really good, particularly with the treatment with prednisolone offering such a positive benefit to these cases. And often full surgical resection is very, very challenging or not possible just because of the anatomical location of these masses and the fact that those ones in the pylorus and duodenum can impact on the biliary tract, the drainage of the gallbladder, for example. So sometimes surgical resection is not really an optional or very, very difficult, but still the prognosis can be really good. This predisposition for ragdolls, I can't emphasize this enough, 14 times the odds risk ratio. So if it's a ragdoll with a mass in the duodenal area, this has got to be on your list. The importance of prednisolone in controlling this disease. And if anyone hasn't looked at Petra's study, I would really urge you to do that. And then a bit more worryingly, some of these cases might actually turn out to be a specific form of lymphoma that does appear to be quite biologically aggressive. So we need to be better at identifying these earlier on. And particularly for pathologists, we need to get our eye in and spot these ones. And then finally, we still don't fully understand the etiology, even 16, 17 years on, but we're working on it. So please do watch this space. And I hope that we'll have a lot more information for you all once we finish this big study that we're working on now. So watch this space. And then finally, just some of the references to the papers that I've mentioned in this talk. There's not a lot of publications. If you go to PubMed and type this in, you will find all of these on there. But the key ones, obviously, that I've mentioned, being Petra's paper, Lyndon Craig's original paper, and Michael Linton's study from 2015, are all really well worth reading. And then lots of acknowledgements to the guys at CVS for helping with that initial study that I did. From my colleague and friend Aga at Nottingham, who encouraged me to do that retrospective study, to those involved in the case report, to Petra herself at the University of Georgia. She's just an endless source of energy and enthusiasm for doing this work. To my fellow pathologist Alex at the University of Edinburgh, who's been working with me to assess all of these cases histologically and to do all the scoring. And then to all the practices, the vet schools, the reference labs, everybody who's supplying cases to the big study, a big thank you, because we can't do these studies without you. And then also to all the vets and the owners that are involved in that Facebook group that I mentioned. It's well worth looking for them if you've got a case and you just need a little bit more support for that owner. They're very, very friendly, very, very inclusive, and I suggest that you have a look for them. And with that, it's time for any questions. If anyone has any questions, I can see there are some in the chat box, so we can work through those now. Let's have a look. 18. Okay, so I've got a question from Abigail. Now, bear in mind, I'm a pathologist, not a clinician. So there's a big caveat here for all the clinical questions. So Abigail has asked, where's she gone? Is long-term corticosteroid therapy required for these cases at the lowest effective dose? Can you consider cyclosporin as part of the maintenance? Again, I'm not a clinician, so I'm not the absolute expert on treatment. The cases that I see and I follow on the Facebook group, a lot of them do seem to need corticosteroid therapy long-term. You can try reducing the doses to find the lowest dose that works, but some of them then relapse and you have to obviously increase the dose. In terms of other treatments, I'm not the expert, so I wouldn't be the person to give you advice on that, but people do add in the secondary immunosuppressants as well. So, you know, that's definitely something that you can consider. More questions about is the PRED long-term or is it a course? Again, from some of the cases that I've been following on that Facebook group, it's a long-term control. And sometimes, you know, you can try and wean down the dose. Sometimes they do okay, sometimes they relapse and you have to bring it back in. But I'm not the person to give you details on you know, the doses, etc., etc. I'd suggest that you read Petra's paper. She's got a lot of information in there. So that would be a good place to start. Duncan, is there any relationship with the more well understood eosinophilic granuloma complex syndrome? That's a great question. I've been wondering that for a long time. Is this just EGC but in the gut? And I do wonder if there might be something similar. Yes, we don't necessarily see the fibroplasia in the EGC complex, so that would be slightly different. But yeah, I do wonder if it might be similar, and hence why PRED works. Sometimes the diet works, so it could be there are multiple different contributing factors. Again, the genetic predisposition perhaps might play into that as well. So yeah, it's a really, really good question. Claire's got a question. Is cytology from FNA of a mass useful at all? So I'm not a clinical pathologist. I'm a histopathologist, but my understanding is cytology can be useful. It just depends on what kind of aspirate you get. One thing is that these often, I've been told, these often feel quite crunchy and solid when you put the needle in. So sometimes that's a bit of a hint as well. It just depends how many cells you manage to get out of that lesion. So it will be quite a mixed cell population. If you've got eosinophils and fibroblasts, macrophages, that might sort of make your clinical pathologist think of this particular entity. But I have seen it misdiagnosed on cytology as well. So it's probably worth doing, but you might not get a definitive answer. I think that's a fair enough answer to that one. Let's have a look. Do most labs pathologists know to do all these stains, or would we need to request them to decipher between the possible cause of the lesion? I would say most pathologists should have this disease on their radar now, and they would certainly be, they could do the Masson's trichrome, which is the collagen stain, they can do the Gram stain and the PAS stain for infectious agents. Those should be pretty standard, and they would be doing those. And then in terms of the immunohistochemistry, if they've got lymphoma on the differential list, then the T cell marker is quite a commonly used one. The NK cell marker isn't. So that's only recently been published in 2025. So I don't know that particular, the CD56 probably isn't widely available at the moment, but the T cell lymphoma marker is. So most of the pathologists should know that we can use these stains to try and help us work out which particular one it is that we're dealing with. Yeah, so that they should be okay to do that. Do these cats always have a palpable abdominal mass? Can they just present to us with chronic vomiting, diarrhea, weight loss? That's a good question. Depends where the mass is, partly, I guess, as to how easy it is to palpate. So some of them have them in odd places, like the rectum, and that's not going to be so easy. Most of them have a palpable mass, but I guess if the mass is smaller, then you might miss it. So not necessarily, but a lot of the cases that came in, so that retrospective study we did with the 78 cases, a lot of them had mass somewhere in that clinical history. So I think it's a fairly common finding, but as you saw from the word cloud, these can present in all sorts of different ways. So I guess it's just, you know, a palpable mass would have it higher on your list, perhaps. I don't think it would be quite the same as just a diffuse thickening. That would be different presentation to my mind. Is eosinophilia on CBC a consistent finding no matter where the lesion appears, or are the eosinophils primarily found in the lesion itself? So the peripheral eosinophilia is a common finding, but it's not in every single case. So if you have it, then this is definitely on your differential list. So yeah, I don't think that's related to where the lesion appears. So the eosinophils are in the lesion, but also in the circulation. I hope that makes sense. I think that's most people's questions, unless I've missed any at the bottom. Hang on. I'll just see if there's any I've missed. Oh, I've got one. Thank you for this presentation. I was wondering, given the presence of abundant collagen and eosinophils, would we expect to see collagenolithic lesions in feline gastrointestinal eosinophilic sclerosing fibroplasia? Yeah, so there's a lot of debate in the pathology world about using the word collagenolithic, even for EGC. So some people are quite anti-using it. They say it's not really lytic collagen. But that aside, that kind of classic flame figure formation that we see in eosinophilic granuloma complex does look a little bit like that. So in those areas of necrosis that I showed you, it looks a little bit like it, yes. But I don't know that it's not exactly the same thing. So that's something that I would expect to see more in the eosinophilic granuloma complex. Is there someone who is willing to take questions if we feel we have a case on our hands? Internal medicine specialist would be your best port of call. Particularly someone who's got an interest in feline medicine, that would be my recommendation. So reach out to them, and yeah, they should be able to give you some more advice. Did any of these cases present with or have association with eosinophilic keratitis or feline herpes virus 1? Not to my knowledge, no. So I don't think it's a general eosinophilic disorder, but it's an interesting thought. And you do have to wonder if these, particularly with some of the genetic predispositions that might be there, whether there's some underlying factor with these cats and their eosinophils that make them particularly prone to developing these lesions. But that's a good question. Thank you. I think that's everybody's questions, unless anyone has any others. I think that then just remains for me to wrap up and wish everyone a good evening. I hope everyone found that useful and interesting. As you can see, it's certainly a topic that we're learning more and more about all the time. We certainly don't have all of the answers yet, but I hope we are getting there slowly but surely. So I hope you've enjoyed that talk, and I think that's probably it for now. Thank you very much, everybody.